Health services across Manitoba are provided in facilities located on the original lands of First Nations and Inuit peoples, and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation.
Good afternoon and welcome, and thanks for joining us on this snowy Wednesday afternoon. It's my pleasure to welcome you to the second webinar in the Innovations in Mental Health and Addictions Learning series. My name is Bill Smitheringale, knowledge broker with the Addictions Foundation of Manitoba, and I will be your moderator for today's session. As Minister Gordon mentioned, this learning series was created in order to highlight the initiatives that arose from the Virgo report with an eye toward increasing awareness around these projects among both health and social services personnel. Our hope is that these webinars will generate increased interest, referrals, and access to these innovative programs. Today, we are excited to shine the spotlight on the Newcomer Collaborative Community Mental Health Service. We're joined today by Heather C. Robertson, Director of Mental Health Services with Aurora Family Therapy Centre. We'll start today with a pre-recorded presentation in which Heather explains all about the program and the services they provide. Following the presentation, we'll be here to answer your questions. Please enter any questions you have into the area on your screen, and we'll get to as many as we can today. So without further ado, it's my distinct pleasure to introduce Heather C. Robertson and the Newcomer Collective Community Mental Health Service.
Hello everyone, my name is Heather Robertson. I'm the Director of Mental Health Services at Aurora Family Therapy Centre, and I'm happy to be here today to talk with you about the Newcomer Collaborative Community Mental Health Service, which is an initiative our organization has been running since April 1st, 2020. This mental health service aims to provide community-based, trauma-informed, and culturally competent supports to newcomers who have experienced moderate to severe trauma. The collaborative model focuses on bringing together expertise that already exists within community-based organizations, the formal mental health system, and ethno-cultural and faith communities themselves as a way of better meeting the needs of the individuals and families that we serve. A lot of what we do in our program is based on best practices for working with refugees, newcomers, and other highly traumatized individuals that were developed by the Harvard program in refugee trauma. I'll talk a little bit about that later when I talk about what we actually do. Another aspect of our program that's one of the guiding principles is that we try to, whenever possible, incorporate traditional ways of healing and really respect and honor ways that people around the world have been taking care of themselves for generations, and trying to marry that with some of the more Western or formal mental health approaches that we often use. The objectives of our program are really about early screening, identification, and treatment of mental health problems that are related to experiencing that moderate to severe trauma. So we're looking at trying to promote timely recovery and resilience, preventing the progression of severe mental illness, reducing emergency and acute health system use, so really looking at that preventative piece, and then also reducing the long-term effects that we know post-traumatic stress disorder can have on individuals' health, families, and social functioning. There are 6 main services and supports attached to this project, with the main one being long-term individual, family, and group therapy. We have a team of clinicians that are both trained in providing trauma-informed therapy as well as working with various ethno-cultural communities and different faith groups. There's no set limit on how long a person can be in the program or how much therapy they can get. Again, people's individual situations are quite unique, and so it's hard to know how much support they'll need or how long it kind of will take them to process their experiences, deal with some of those ongoing symptoms such as flashbacks, nightmares, intrusive thoughts, difficulty trusting others. And so people stay in the program for as long as the therapist and the participant feel that it's beneficial. We also have a case management service attached to the program, which is delivered by Family Dynamics. We want to acknowledge that there are often many different uh, competing challenges or priorities in an individual's life, and sometimes those get in the way of them being able to attend therapy or really be fully present in their therapy session. These might be things like health issues, issues related to the justice system, housing, access to the basic needs, education, and employment. And so we refer anyone who requires some of that additional support to Family Dynamics to get that help so that it increases their overall well-being. We have a psychologist that works with us from the clinical health psychology. They work on site. So again, trying to create easier access for people. They may feel safer accessing a psychologist in our organization or in a community place that they're comfortable with than going into a big hospital or an office they're not familiar with. This psychologist helps with assessment, case planning with our clinicians, as well as diagnosis. There's a system navigation piece in partnership with mental health services with the Winnipeg Regional Health Authority. And so this person works in the Winnipeg Regional Health Authority, or is employed by, sorry, the Winnipeg Regional Health Authority, but works at Aurora. They have an office in our building and are there to help connect people to our program that might be appropriate, as well as help individuals in our program who might benefit from existing resources or services within the Winnipeg Regional Health Authority that maybe they haven't been able to access previously due to some challenges or barriers within the system. We have a child and adolescent mental health clinician, and that service is delivered by Manitoba Adolescent Treatment Centre, MATC. So we do have kids and youth being referred to us who meet the program criteria, who require some specialized support. So we're happy to have MATC on board providing that service. We also know that when adults or parents have experienced significant trauma, sometimes that can impact their ability to parent in a way where their children are having all of their needs met. And so sometimes we are providing service to kids who haven't necessarily experienced severe trauma themselves, but are definitely experiencing the impacts of trauma in the family system. We have a psychiatrist that is attached to our program. He's employed by Aurora and he provides, again, assessment, diagnosis, can make recommendations on medication. He doesn't follow regularly a lot of the individuals that we work with, but he can do follow-ups and make referrals and recommendations to people's family doctors. Um, a lot of people that we see have a lot of difficulty with sleeping or may have other underlying mental health issues on top of experiencing that moderate to severe trauma that can really make life challenging for them. So it's great to have kind of a timely referral source to send them to. And generally, clients in the program are able to meet with a psychiatrist within 2 to 3 weeks of identifying that that would be something that would be helpful for them. So we're very thankful for that aspect of the service. There's also a component of the program that focuses on mental health promotion activities. So this is done by Aurora's team in partnership with different community groups, different ethno-cultural communities, different faith communities, as a way of increasing people's understanding of mental health. So it's a two-way street really, and we aim to learn as much from the communities that we work with that we hope to teach. So again, acknowledging that different cultural groups, different communities have varying understandings of what mental health is, different beliefs about it, different beliefs about why things happen to people or how family systems work. And so we really want to go out there and gather that information so that we can provide the best service possible. Maybe there's a certain way that a particular culture frames mental health or talks about mental health. And so we want to get that information to inform our therapists so that the service for them feels safe, it makes sense in their worldview. And as part of that, we really want to go in there and start having conversations around some of the stigma associated with mental health and start kind of breaking that down piece by piece and making or helping people feel more comfortable or safe in talking about mental health and coming forward and asking for help when they need it instead of waiting until they're in full crisis and they have to say present at an emergency room. We also provide interpretation for all of our services, so clients can pick what language they'd like to do their therapy in, or they'd like to communicate with whoever on this team is supporting them. We have an amazing partnership with the Winnipeg Regional Health Authority Language Access Information Services, and they provide us interpretation for any part of our program we may need interpretation for. Intakes are done in whatever language the person's most comfortable. And we also provide transportation support when needed, which hasn't really been a thing yet because with COVID, all of our services are being delivered um, over Zoom. The project is guided by an advisory committee with the goal of making sure that we're doing what we started off trying to do, which means really involving community, working collaboratively with the formal system and the individuals that we're aiming to serve. The advisory committee meets on a regular basis and it's made up of representatives from the project partners, different stakeholders that support newcomers, people from different settlement agencies, and then also community leaders from different ethno-cultural and faith communities around the province. This has been a really amazing experience so far, and we hope to grow this aspect of our program as we move forward to really ensure that the service we're providing is meeting the needs of the people that we're serving. So the goal of this is really to provide guidance on best practices for engaging newcomers in program, as well as providing programming that is culturally safe and appropriate. We also want to make sure that we are working collaboratively together and that groups or aspects of the population that we're trying to serve are not being left out. And then again, learning about and trying to incorporate traditional ways of healing and spirituality. So acknowledging there's a lot of different ways that we can be supporting newcomers who've experienced trauma and that no one way will be valued over another, and that we as service providers have much to learn in providing culturally safe um, services. The scope of the project, so as I said, we began on April 1st, 2020. I actually accepted the position of team lead to oversee the project on March 13th and then never went back to the office. So it has definitely been challenging, starting a program and getting everything ready and trying to roll it out in the middle of a global pandemic. This program is open for all newcomers who reside in Manitoba. Originally, the program was focused on Winnipeg with the idea that we could provide some consultation to practitioners, therapists that are working in rural areas. But with the move to Zoom, to virtual services, we actually were able to all of a sudden provide service to anyone, anywhere in the province. And we have had quite a few referrals from rural areas, and this is something that we're hoping to increase in the near future. And again, the scope of the project really is about providing that wraparound programming, making sure that we're meeting the needs of an individual in as many areas of their life that we can. The staffing component of this program can be divided into kind of two separate areas, which is internal staff positions and external staff positions at our partner organizations. So for internal staff positions, we have a full-time administrative support person who helps uh, keep keep us on track, helps with file maintenance, helps with making sure that people who are calling are referred to the appropriate person. Very key person of the project, and we feel very grateful to have someone who is very organized and dedicated to the position. There's a full-time team leader, which is my role. I work on overseeing the project, ensuring that the partnerships are going well, ensuring that we're communicating to stakeholders, overseeing the service delivery, and doing all the fun stuff like reporting and data. Originally, we did not have a separate person identified to do referral and intakes. This was going to be a rotating position among our clinicians, but the number of intakes the number of referrals that we've received for the project has been quite overwhelming. And our original goal of, meeting with every referral within 1 to 2 weeks of it being received was just not possible. So we did some advocating for ourselves, and as of November 1st, this month, we actually have just hired a point 0.5 referral and intake lead. So this person is responsible for ensuring that all referrals make it to us and are recorded, and that intakes with those individuals are organized in a timely manner. We have the equivalent of 4 full-time clinicians. So right now our team is made up entirely of marriage and family therapists who, like I said, all have experience in working from a trauma-informed perspective, as well as working with individuals from various ethno-cultural communities. I think almost all of our clinicians are actually newcomers themselves, and so I think that provides um, really good support for the people that we serve, because they have that understanding of what it's like to come to Canada and some of the experiences and challenges and feelings and thoughts that are associated with that. And I think it really helps create some commonality between our clinicians and our participants, and helps establish a level of safety and trust. And then we also have a point 0.1 full-time equivalent psychiatrist. So he's with us twice a month. He does consults with our staff if they have questions about a specific issue, and then he meets with clients directly and does some of that assessment, diagnosis, and recommends medication or follow-up. There's 4 positions that are attached to our partner agencies. So the first one is a full-time equivalent position, a case manager position at Family Dynamics. Originally, we had thought that this would actually be one staff person that would support all the individuals and families that were participating in our program. However, we realized that some of the people that were getting referred to our project already had case management services through Family Dynamics, and we didn't feel that it was in their best interest to, make them transition to a new case manager. We wanted them to stay with someone who they had a relationship with, that there was a level of safety, and so this full-time equivalent position is broken up into, however many case managers there are at Family Dynamics, just to ensure there is that continuation of care for people who are already accessing services. The psychologist works half time at our organization. The child and adolescent mental health clinician also works half-time, and the cross-cultural mental health specialist, which is through the mental health services at the Winnipeg Regional Health Authority, is a full-time position. This is the system navigation position that I talked about earlier. And really, this person's job is to help people navigate the formal system and access services that might already exist, but just they didn't know about, or for whatever reason, there was some sort of barrier for them to participate. All of the psychologist, the child and adolescent mental health clinician, and the cross-cultural mental health specialist will all be physically located at Aurora. So again, bringing some of those outside services that exist right to the Aurora space. So when clients are coming to access services, they're all in one place, which will really help them access those services that they need without creating additional challenges or barriers. So, who exactly am I referring to when I am saying newcomers or participants or clients? All newcomers in Manitoba basically qualify for our program. So, the province says, immigrant, refugee, ethno-cultural, and racialized populations, or IRER, are eligible for this program. So, that includes government assisted refugees, privately sponsored refugees, refugee claimants, immigrants from a non-refugee background, international students, temporary foreign workers, and naturalized Canadian citizens. So unlike other funding streams or other projects, this is really a broad eligibility. There are groups or demographics within this list that aren't usually allowed to access programming that's designed for newcomers because they don't have either permanent status in Canada or they've become a citizen. And the thought is, well, once you become a citizen, you don't necessarily need programs designed for newcomers anymore. Eligible program participants need to be residents of Manitoba. They need to have that history of some sort of moderate to severe trauma experience, whether that's a one-time event or kind of ongoing multiple complex trauma. What we're looking for is individuals that are dealing with the symptoms of post-traumatic stress disorder without necessarily requiring them to have a formal PTSD diagnosis, because that can be a barrier for some people. And we're also looking for people who are experiencing challenges in their day-to-day functioning related to the trauma they've experienced and or another ongoing mental health issue. So again, recognizing that not everyone who experiences trauma is going to feel the impact or the effect of that trauma for a long-term period, but that many do. We have an open referral process, which means we basically accept referrals from anywhere that they arrive from. This includes people referring themselves to the program, so they've heard about it somehow and feel that they meet the criteria or might benefit from the services. Clients who are in the program are sending us their friends and families, community members or community leaders that are maybe supporting individuals that are having a hard time and it's got to a point where it's beyond their capacity to help, are sending people our way. Settlement agencies, non-settlement agencies, so people that are working directly every day with newcomers, and organizations that aren't, but have a newcomer here and there and they're saying, listen, I think that you need something more than what we can offer. We're getting lots of referrals from the education system, whether that's the K-12 or post-secondary. And then more and more referrals coming actually from the health system. So newcomers are showing up at, let's say, the crisis response center, and the people there are saying, this is what we can do today, but we would recommend that you kind of seek out longer term services to help you with what's happening. Our aim is to complete an intake within 2 weeks of receiving a referral. So we were doing pretty good for a while. As I shared before, earlier this summer, we just got a little bit inundated and overwhelmed with referrals. And so the wait time did go up. But we're hoping by December 1st, that'll be back down to those 2 weeks. We do an intake with all of the referrals really to ensure that they're meeting the criteria of our program and they're a good fit. Uh, our capacity is about 40 to 60 individuals a year. And so we really want to make sure that the people that need this program are the people that can access it. And we also want to make sure that the program is a good fit for the individual that's being referred. Perhaps they actually might benefit from a different project somewhere or a different program somewhere. And so we want to make sure they end up where it's going to be most helpful for them. We do further assessment after doing that initial eligibility screen. So once they have been accepted into the program and matched with their therapist, we use 3 different tools to determine kind of what's going on for them, how we might be able to help best. And those tools are from the Harvard Program in Refugee Trauma. There's the Harvard Trauma Questionnaire that has 4 parts. Most of it focuses on symptoms and the severity of those symptoms that the person is experiencing. But there is a part that has just yes or no questions that actually asks people about whether or not they've experienced certain kinds of trauma. And I know that there are, I think, varying ideas around whether or not we should be asking people these questions. But the research that, the program in refugee trauma has done has actually showed that this is very beneficial. There's often a lot of shame associated with some of these traumatic events, and people don't want to share that it's happened to them. They have never told anyone before, and sometimes it's because nobody has ever asked. And so the research that they're doing is actually showing that when people are asked these questions and they can finally say, like, yes, that has happened to me, that it's actually quite beneficial and kind of gets that secret out into the open so that they can finally kind of address it. We don't go into any more detail other than yes and no, and the assessment does give a score at the end, and shows whether or not someone is symptomatic for PTSD. We also use the Hopkins Symptom Checklist, which was also developed by the Harvard Program for Refugee Trauma, that assesses anxiety and depression, and again gives a score and shows whether they meet the DSM criteria for those 2 mental health issues. And we also use the WHO, the World Health Organization 5 Well-Being Index. And so that's just 5 questions, and it's, how have you felt over the past week? It also has a score, and we record all of that information. The benefits of using these assessment tools is that it does help the clinician know what's going on with the client and what symptoms they're really struggling with. But it also provides an actual uh, quantitative number in terms of the severity of their symptoms and what they're experiencing. So these are actually repeated every 6 months, and we can use them as an evaluation tool to see if there's been a shift in the symptoms that the person is experiencing. So, is this program working? Are we actually, creating positive change and enhancing well-being? Uh, for the first, I guess, 15 months of the program, that's what I have data on. Approximately 85% of the clients or participants in our program did score symptomatic for depression and anxiety upon entry into the program. So they're coming in, if they don't meet the criteria for the PTSD or symptomatic for PTSD, then we reassess and say, is this the right program for them? So basically 100% of our clients meet the criteria for PTSD, and 85% of them are also testing symptomatic for depression and anxiety. So they're coming into the program with a lot of different challenges and a lot of symptoms that are creating just day-to-day difficulties for them. Project statistics. So since April 1st, we have received 141 referrals. 107 of those were screened. So sometimes we do get referrals, and when we follow up, we can't get a hold of a person. So whoever sent the referral on their behalf was kind of hoping that maybe they would follow through and possibly could benefit from it, but we just haven't been able to get a hold of them. Out of the 107 referrals, 82 were registered. 87 were registered, which works out to be 82% of referrals that we receive actually meet program criteria. On top of the 87 primary clients, 10 additional family members were provided service. So that is, excuse me, a partner, a child. Sometimes it's an extended family member that they live with that, could also benefit from service. We've had over 1,300 clinical contacts. 21 clients have received a psychiatric assessment. There's been 30 psychology consults and assessments. 10 families have received case management, and those are 10 families within our program that weren't already receiving case management. So there's actually a huge number of our clients that are receiving case management, but they were receiving that support before they made it to the program. And actually, sometimes it's the case manager that's referring them to us when, it becomes apparent that there is trauma or a larger mental health issue. And approximately 54% of our clients are provided with interpretation. So it was thought when this program was created, when we went, that, it would be 100% of people who are participating in this program would require interpretation because they would be newcomers. But we're actually finding is that quite a few people who are being referred to our program have actually been here for quite a long time and have built up their English language skills and would like to participate in therapy in English. We always give the participants a choice, and we do have some clients who have very strong English language skills who say, you know what, I feel more comfortable being able to express myself in Arabic, and so we arrange an Arabic interpreter. We also do have, I think, 4 or 5 different languages represented among our clinicians. And so even if clients don't have high enough English language skills to participate in therapy, they're still able to receive therapy in their first language because the clinician speaks that language. So project statistics, what does that look like in, some graphs? You can see program referrals by reporting period. So we started out April 1st, 2020. In the first quarter, we got 20 referrals. Almost all of those were internal referrals. With the creation of this program, we also had a funding change in another program. And so there was a bunch of individuals that had been getting service there that could no longer. So they were internally referred. With the pandemic, things slowed down a little bit, and then you can see they significantly increased. So in April to June of this year, we got more referrals than we almost had the whole entire previous year. So as I said, it was a little bit overwhelming, created a little bit of a bottleneck, but we're still working through that and hoping to get everyone's service very quickly. And then over this past summer, there was 28 referrals. So in June, I think a lot of schools and English language programs or settlement programs break for the summer. And I think there was maybe a little bit of a rush or a panic to ensure that people had the supports that they needed over those summer months. And so that's, I think, partly why we saw that big jump. Participants by immigration category, we are seeing that government-assisted refugees is the largest demographic that is accessing our program. This is not, doesn't include people that were referred in the program and didn't meet criteria. These are people that were met criteria and registered in the program. So government-assisted refugees, the next category is actually international students. So a lot of people who have come over here for post-secondary, but have experienced some pretty significant trauma in their lifetime, or have come to Canada specifically because it's not safe back home. Within the international student category, there's quite a high number of international students that identify as being LGBTQ. So again, did not necessarily feel safe in their country of origin and really needed to get out of there and find a place that is safe. Canadian citizens is actually the next highest category, and I think again that shows that oftentimes when people are immigrating to Canada, those first 2, 3, 5, 7 years are focused on meeting, their basic needs, finding a place to live, getting a job, getting financial security, establishing themselves. And it isn't often until they actually feel like they can take a breath and have that financial stability and feel like they've settled, that they're in a place that feel ready or safe enough to deal with some of that trauma that they've experienced in the past. The next categories are privately sponsored refugees, so often have the same experiences as government assisted refugees, but they just get to Canada in a different route. We are seeing quite a few refugee claimants in the program. I think it's important to note that refugee claimants and international students are two categories that are often not eligible for federally funded settlement programs. So I think that's also why we're seeing a high number of referrals, because there's aren't a lot of other places for them to go. Our top 5 countries of origin, so out of all of our 87 participants that have been registered to date, the top 5 countries are Syria, Iraq, India, Bangladesh, and then Somalia and Nigeria were tied for 5th place. I think Syria and Iraq definitely represents what we have been seeing happening around the world in terms of different conflict and the number of people that Canada is resettling. The top 5 languages requested. So the first one is English. Again, a lot of international students, it makes up 13% of our program are coming here with advanced levels of English. So that, in addition to people who have been here a long time and have become Canadian citizens, it's making English the most popular language. So about 50%. And then next is Arabic, Kurmanji, French, and then Punjabi and Somali tied for 5th place. Program participants by referral source. So internal referral source continues to just be the top. And again, I think that's skewed by that first quarter of our program where a high number of participants got shifted over from one program to this. Self-referral is the second highest category. I often go out and do referrals to service providers, and they're finding out about this project and then actually saying, hey, maybe I could benefit from that, or are doing, independent research on services that might be available and finding their way to us by themselves. Community referrals is the next one. So this is either community leaders, just, someone heard about this project and says, hey, my friend needs this support, and makes a referral on their behalf. Post-secondary is the next one. So again, we're getting a high number of international students. And then settlement, service providing organizations, health, and then the K-12 education system. We're still trying to increase the number of referrals we get from there. The challenge is that we're nearly at capacity. And so, we want to be able to go out and promote the program and say, hey, we have this great service, but also, don't want to go out there and say that and then just have people stuck on a wait list. So we're trying to clear kind of, like I said, the backlog that we have right now. And then we're continuously, advocating for additional funding to be able to increase the number of clinicians. And we actually have already increased the number of clinicians that were originally assigned to this project by 1 full position, just because there was so much demand. Program participants by years in Canada. So the highest category is actually individuals who have been here for over 10 years. Again, reflecting the fact that those first years in Canada are really often about survival. People are not thinking about their mental health. They're thinking about, how do I get through day by day. They're focusing on, helping their kids, and it isn't until they have that a little bit level of security in their life that they're kind of saying, okay, I'm ready to get some support with this. The next two highest are years 2 and 3. We see that, I think, reflected often in self referrals as well as international students. And then 5 seems to be a big mark as well. When I did this last week, there was only one person who had been referred to our program and met criteria that had been here less than a year. But since we've got 4 more referrals in that category. So I think as more and more service providers and just the general population hear about this program, we're going to start seeing all these categories increasing. I don't know how well you can see this. I tried to just kind of capture on a map. If you look and see where people are coming from in terms of areas of the world. So the darker the yellow, the higher number of people. So you can see there's a pocket with Iraq and Syria. India is also an area where we're getting lots of people, as well as Nigeria and some other countries around Africa. And then we just actually are starting to get a couple referrals for newcomers who come from South and Central America. So, just kind of neat to see it sometimes in this context. So success stories. Number one is we launched a program during a global pandemic. Like I said, I took the job and I never went back to the office. And so at the beginning of this, we just kind of thought, like, how are we going to do this? But we managed to do it. So I think, we, along with a lot of the other the initiatives, were also in the same situation. That in itself, I think, is something to celebrate. We have a high number of referrals from community members, ethno-cultural groups, and participants that are currently in the program. And to me, that's the biggest success. We're aiming to support newcomers from various ethno-cultural communities, and if those communities and groups are referring people to the program, it means that the people in the program are benefiting. It means that they're hearing good things. It means that they're seeing a difference. We know that they're not going to send people to programs that they don't think meet the needs of their community. And again, program participants who are accessing services, who are referring family and friends, you don't send your family and friends somewhere where you don't feel safe. And so to me, again, it's one of the biggest successes. In part of doing some of the evaluation for this program, we were able to do some surveys for program participants who had been in the program for more than 6 months. And the initial feedback from those surveys showed that, or supported that the clients are having a positive experience in the program and that they're actually experiencing positive change. Those were surveys that were done by participants, and the numbers from our assessment tools that I spoke about earlier also support that people's overall well-being is increasing and the symptoms that they're experiencing are decreasing. We were able to form a really amazing partnership with the Winnipeg Regional Health Authority Language Access Interpreter Services. So as I said before, they're providing interpretation free of charge for our program, which is absolutely amazing. We have some interpreters on staff for some of the languages like Arabic and Kurmanji that are quite high in demand. But for us to be able to provide language in, I think, the 25 different languages that our program participants speak, it would be difficult for us to do financially. So that's another area that we didn't think was going to be a thing when we started, and we're very grateful for that partnership. And then I think the last success story is that we've really been able to do some early screening and connect people to crisis supports. So when I receive a referral or when I'm calling for an intake or doing an intake, it's quite apparent that this person is not okay, that they're really struggling, that there are some potential safety concerns. And through, the relationship with the referral source, or just even through the relationship that we have with that person in the intake meeting, we actually were able to connect several people to crisis services who were yes, at very risk of harming themselves. And that's actually included, staying on the Zoom call with them as, mobile crisis got sent to their house. So again, I think these are sometimes services that people wouldn't necessarily feel safe accessing, but really need in that moment. And so that's I think a really big success as well, that we're able to connect people to places that they wouldn't have gone previously, and also give them that long-term support that will help them um, for the rest of their life. Challenges. I was going to put the number one challenge, delivering a program during a global pandemic. So that obviously has been a challenge, and I'm not sure I have to go into too much detail, as it's something that we've all experienced and has created a lot of challenges in all aspects of our life. One of the big ones for us was, a lot of our participants didn't necessarily have access to technology. So it was very difficult for them to do Zoom meetings because they didn't necessarily have a phone or have a laptop or have an email address. Thankfully, we have some really amazing staff at Aurora, and a lot of the staff in our community development program actually helped and kind of, would go to someone's house and stand outside their house and hold their phone up and be like, this is how you do Zoom. And we were actually able to get all of our participants connected to remote services. um, and again, a big thank you to the Winnipeg Regional Health Authority Language Access Interpreter Services, because I'm sending them Zoom info, they're giving it to the client when they're booking the appointment, and then everyone just shows up at the time with fingers crossed, and hoping that people have been able to figure that out to attend the session. So I think the other piece around delivering remote and virtual services is some of our participants, live in an apartment with a lot of people, or have a lot of children. And when those kids were not in school, it created challenges to find a private space to meet with their therapist. And so, we were doing therapy with people while they were sitting in their car outside their house, or when they were, sitting in their bathroom, trying to talk. But I think we needed to get creative in order to provide, a much needed service. Finalizing partnerships with external stakeholders. So this definitely took longer than we had hoped. The pandemic did not make it easier because it was difficult. Well, we couldn't meet in person, and everything had to be hashed out over Zoom or via email. And we're not a health organization. We're not a part of the Winnipeg Regional Health Authority. And so, we were trying to make, LOUs and partnership agreements with some pretty huge, complicated, ever changing institutions. And so that did create some challenges. And actually, we just hired our last position this August. And so it took, 18 months of just back and forth and trying to find the right person, and trying to really, have clear expectations as to what the person would be doing. And the last challenge is there's a high demand for service. And so right now, as I speak today, there is no wait list. 10 days ago, there was. So people can stay in the program for as long as they need to, and the therapist thinks it's beneficial. And so people are always finishing. We have space for new people to come in, but pretty soon again, we are going to have a wait list. And so it ebbs and flows, but I think our statistics show, our graphs show that, increased demand for service is going to continue. And so this will be something that will, I think, continue to be a challenge. Future projects. So right now, this is, one of the pilot initiatives out of the Virgo recommendations. We're hoping to be able to secure funding for the continuation of the project. I think we've been able to show that, there's a demand for the project, that people are benefiting from the project. There is a need, and so that is kind of one of our main focuses right now is, what's going to happen after March 2020. Again, looking at trying to secure additional funding, from maybe a variety of funders to increase the number of clinicians to keep up with this demand for service. We want to continue community conversations. So through our advisory committee, we've been able to have a lot of amazing conversations with, leaders from a lot of different community groups, and they've been able to share with us, why people from, their community don't tend to access formal mental health programs or, what might be helpful. But it's been hard to have really in-depth conversations because often those conversations are best done in person, where you can take the time to create a relationship and establish safety. And unfortunately, COVID has made that difficult. So this is something we're definitely, as we kind of return to, normal, whatever that is, that we want to increase those conversations and expand the mental health promotion activities. We really felt, I think, in having conversations with our advisory committee group, that this is best done in person when those relationships have been built. And so that is something that we're hoping to focus on in the year coming up. I will note, just going back to challenges, I think one of the things that we're struggling with and trying to figure out right now is that there is a higher percentage of vaccine hesitancy in some of the communities that we support. And so what does that mean for return to in-person services? How do we ensure we keep our staff and our clients safe? And so that's, again, a conversation that is ongoing and changing as, the COVID landscape changes. And that's it. I hope that I was able to provide you with a really clear overview of what our program is, what we're aiming to achieve, what kind of services are available to the population that we're supporting. I have my contact info here. I also know that this presentation will be available to watch in the future. If you just loved it so much the first time, you'll have an opportunity to watch it again. Feel free to contact me, reach out. We are still working primarily remotely, so email is always the best way to get a hold of me, but I do still check my phone. Thank you to everyone who's helped make this project such a success, and we really look forward to continuing the work we're doing and expand as needed, hopefully. And I think we're going to turn it over to some questions. Thank you.
Well, thank you so much, Heather, for a very, very comprehensive and informative presentation. Really enjoyed that. It sounds like it's an excellent program. We do have a few questions here that we like to squeeze in our last few minutes. So I'm going to share the first one with you, Heather, is what are the, oops, my questions just jumped. I guess more coming. Let's see, what are the costs of these services? Often finances are a huge barrier to people when accessing mental health services. And also, is it just residents from Winnipeg who are eligible?
When I saw this question pop up about how much services cost, they said, oops, I should have included that in the presentation. All of our services are free of charge. This program really is about trying to increase accessibility to mental health programming and reducing barriers. So everything is free of charge, and we do also provide transportation support, and we'll go out and do appointments in people's homes and the community once it's a little bit more safe to do so, to further reduce barriers. Program is not just for people in Winnipeg, it's anybody who lives in Manitoba. So small silver lining of the pandemic is that we've shifted to virtual services, and so we can provide service to people all over the province.
Perfect. Thanks so much, Heather. I may have been muted in asking that first question, but I think from the answer they will have figured out what it was. So next question is, how does the referral process work for those who are referring on behalf of an individual? Is there a referral form? Where are referral forms sent? Or who is the person to contact for referrals?
So right now, it's me. As I mentioned, we did hire a half-time referral and intake lead. So hopefully by the end of November, there will be a new contact. We do have a referral form. So if you go on our website at Aurora Family Therapy Centre and click on the Newcomer Collaborative Community Mental Health Service page, at the bottom is my contact information. And so you can send me an email if you have questions about someone you may want to refer, and then I will send you the referral form. I think that we're also going to try to send out a link for a referral form when this presentation is made accessible. And then I'm going to actually try to get the referral form put on our website so it's accessible there.
Perfect. Yeah, so we'll have a link where this recording is available, which is, I believe, on your screen. At the bottom register for the session, that's also where you can view past recordings. And this one should be available within just a couple days. So we'll squeeze in a couple more here. Someone asking about the assessment forms that you use in the program.
Yeah, so there's three. There's the World Health Organization, the WHO 5 Wellbeing Index. The two that we got from the Harvard Program for Refugee Trauma are the Harvard Trauma Questionnaire, the HTQ, and then the other one is called the Hopkins Symptom Checklist.
Okay, perfect. I hope you all had your pens out copying that down. So a few more. Question about the funders, and are there social workers that work at Aurora?
So this program is funded by the province of Manitoba. Came out of funding that was made available after the Virgo report recommendations. Are there social workers that work at Aurora? Yes, there are. In our program, the clinicians that we have all happen to be educated with their master's in marriage and family therapy, but we do have social workers that do work at our agency.
Perfect. Someone's just asking to repeat the referrals again, just a little slower, just because
Sure, I know we're short for time, so I was trying to get as much info in as possible. My contact information is on our website under the Newcomer Collaborative Community Mental Health Service page. It was also in the presentation, which will be made available. So right now, the referral process is you contact me. There is a referral form which has been sent out to a lot of different places, but if you don't have it, just send me an email and I will send it to you, and then you send it back to me. We will have a new intake and referral person that will be organizing that by the end of the month. So that process might change. So just keep an eye on our website and I'll make sure that all of the information is there.
Okay, I probably have time for one more here, Heather. So it said someone's asking, do background conditions, PTSD, depression of clients have to be of previous existence before coming to Canada, or also if they have developed these while being newcomers?
Good question. So I would say that we work with people that kind of fulfill both of those conditions. So some people that we work with have experienced, severe trauma before coming to Canada, but others have experienced things in Canada that that are significantly impacting their well-being. So it can be something that happens post immigration or post settlement. As long as it's kind of impacting their day-to-day functioning and counts as, a moderate to severe trauma, they would be eligible.
Okay, perfect. We are actually just over our 2 o'clock. So I really want to thank Heather for such a wonderful presentation and so much information on what it sounds like an excellent program that is serving a lot of folks and really fitting a need. So that's really great to hear. Thank you all for joining us today. Just want to remind you that the sessions will be available at the website shown on your screen. The last session was on the rapid access to addictions medicine. So that is already up archived and available for view on demand. And lastly, I want to remind everyone that this month from November 21st to 27th is Manitoba Substance Use and Addictions Awareness Week. We have a number of events planned. We'll have a launch on November 22nd, virtual launch starting at 1 o'clock, and also a webinar series that's going to run through the week. And I'll just read off a few of the sessions we have planned. So on Tuesday the 23rd, we have a webinar looking at the successful collaboration with the Newcomer community partners through the Newcomer Youth and the Family Outreach Program. Presenter Tanis Ross. On Wednesday the 24th, we have Building Bridges Collaborative Processes Enhance Integration of Co-occurring Disorders Treatment. Presenters are two clinical specialists, Caroline and Gahungu, I don't think I've ever pronounced her last name, and Jessica Johnson. On the Thursday, we have Giselle Demules giving a presentation on driving change together. One thing that is universal truth is that change is constant, and how do we deal with that? And on the Friday, Amanda Rose Bouguet presents on housing and addictions, a systems approach to housing supports initiatives. So lots to look forward to. Please join us then. And in 2 weeks, we have our third installment with the CEDVIT program. And please, we'll send out a reminder. So please join us then. Once again, thank you all for tuning in today, and all the best. Take care.
Thank you.